respected Emeritus Chairperson Sir, Vice Chancellor Sir, members of the CCR Review Committee, esteemed faculty, and dear students. A very good morning to all of you, and welcome to this today's CCR, which is being presented by my department, that is Radiation Oncology. Next couple of minutes, I'll be giving you a brief overview of my department. The department was established in the year 2014, and we started MD course in the department in the year of 2018, and this course was approved by NMC in the year 2021, and since then we are taking 2 candidates every year, and this year we have applied for the enhancement of these seats, and the result is still awaited. We have also applied for starting MSc Medical Physics, because MSc Medical Physics is a very integral and supportive specialty as far as radiation treatment and delivery is concerned, and they also look after the safety aspect of radiation. Currently, we are 6 faculties in the department. There are 3 professors, 1 associate professor, and 2 assistant professors. Dr. Sumit, Dr. Shikha, and myself are the professor. Dr. Anushri is associate professor, and 3 of us are alumni of this institution, namely Dr. Sumit, Dr. Shikha, and Dr. Kavita. These are the candidates who have passed out MBBS from our institution, and they are well placed either as faculty in medical college or consultant in a reputed hospital or senior resident. This is a slide showing the current students. We are taking 2 students per year, so we have 6 MD students, and currently we have 1 SR also with us. This is a team of medical physicists, though we have a team of 7 physicists, but currently 2 of them have left, and we are carrying forward with 5 of them. In addition to the treatment and clinical practice, we are actively contributing towards the academics. This is a glimpse of the papers published by the department, and just to mention that during the last 5 years, we have published 25 papers in various peer-reviewed national or international journals. This shows the active participation of our faculty in various conferences and seminars. Students in our department are also actively involved in participating in seminars and various conferences. The department is actively taking participation in the multidisciplinary tumor boards, which are very essential for the optimal treatment of the patient. We have 2 linear accelerators for external beam radiation therapy, and we also have a high dose brachytherapy in our department. We also have a dedicated mold room so that the customized immobilization techniques or devices are prepared as per the requirement of individual patient. This is a picture from our treatment planning system, because once we get the simulation data from the CT simulator, we import the data in the treatment planning system, and we do the contouring and identification of the organ at risk, and then it is handed over to the physics department for treatment planning and further evaluation and verification before the execution of the treatment. Recently, we are equipped with the latest technology in the field of radiation oncology, that is CyberKnife, which is a robotic platform for stereotactic body radiotherapy. So with the help of the gadgets available in the department, we are able to deliver all kinds of latest technology technique uh, required so far for delivery of radiation treatment. Department is busy and high volume center. The number of patients is ever increasing. On an average, we are treating 100 to 50 cases per day. The machines are working since early morning till late night. And the graph is very clear to show that the workload in the department is increasing consistently. After the commissioning of CyberKnife in the month of February, we have so far treated 60 cases on this machine, and that includes patients from different anatomical sites as per their indications. We are treating the patient, not the disease only. So we always aim at a holistic approach. So we take care of the psychosocial problems, oncopsychological problems, and other treatment-related or post-treatment complications of the treatment. So this is the slide which shows that we are having regular meetings with the patient and their attendants with our psycho-oncologist. That is twice in a month on alternate Fridays. We are also collaborating with the physiotherapy and rehabilitation department, and occupational therapy department is also collaborating with us because many patients they are elderly group, so they have various comorbid conditions which may be initially there, or there may be some complications because of the treatment or because of any illness. So every aspect of the patient care we try to take care. So with this brief introduction, I would now invite Dr. Diksha for the case discussion.
Thank you so much, sir, for giving brief introduction for our department. Now, very good morning, respected dignitaries, faculty members, and my dear friends. I am here to discuss combined clinical rounds with the case of 58-year-old male with recurrent carcinoma prostate. So today our presenters will be myself, Dr. Kavita Bhati ma'am, Dr. Anshul Sood, and Mr. Praveen Kumar. 58-year male, teacher by occupation, resident of Kota, with no history of addiction or comorbidities, with no significant family history, presented with complaint of sense of incomprehending of bladder and dribbling of urine, which was gradual in onset, progressive for past 6 months. Had no urinary hesitancy or urgency, without pelvic pain, no blood in urine, and without history of fever. As the patient's history is very long, so I would like to take you all through past history of the patient. In 2010, patient had similar complaints. Patient's reports were evaluated outside, which we tried to gather, but we cannot as the past history was very long. Radiological imaging and PSA titers records are not available. All we could gather was biopsy that showed adenocarcinoma prostate. Thereafter, he was advised pelvic radical radiotherapy, but patient refused to do so. Followed by medical management that was GnRH antagonist 3 monthly for 3.5 years outside, followed by tablet bicalutamide.
So did you have in your biopsy report the Gleason score?
No, sir. Actually, we tried to evaluate the reports again and again. We asked the patients, but he said that it's very long history and we lost all the reports. We could gather all these reports from the discharge assembly. Patient compliance was poor and took treatment irregularly. Case summary till now: 44-year male, no comorbidities, diagnosed case of carcinoma prostate, received GnRH antagonist for 3.5 years, followed by tablet bicalutamide.
Is 58 or 42?
So before, in 2010, 58 is the was current age. In 2016, patient again had similar complaints, a sense of incomplete emptying of bladder.
So, just a minute. LHRH agonist or antagonist?
So, how much we recalled and which we evaluated patient, and discharge summary was mentioning GnRH antagonist only.
Antagonist, you don't have any 3 monthly progression. You only have 3 monthly per week.
Yes, sir. I even asked the patient again and again. Even checked the discharge summary. That was done by outside hospital from Jaipur, but it was mentioned there.
Doesn't matter. Agonists are only long at antagonists are daily.
Patient had similar complaints in 2016 also, with sense of incomplete emptying of bladder and dribbling of urine, which was since 4 months. Now this time he also had a complaint of pain in right iliac region since 1 month, for which he underwent PSA, which showed 18.77 nanogram per ml, which was higher. MRI showed heterogeneous signal intensity in prostate with no involvement of seminal vesicle or capsular breach or pelvic lymphadenopathy. Here, it suggests that this is a suspicious case of prostate malignancy. Along with that, some altered signal intensity was seen in posterior aspect of the right iliac blade. That suggests suspicious of bone metastasis, which was confirmed by bone scan. Patient then received radical radiotherapy to a dose of 78 gray by 39 fraction to prostate and regional lymph node from 30th March 2016 to 23rd May 2016 in Tertiary Care Center, Jaipur, followed by radiosurgery to a dose of 14 gray by 1 fraction to posterior aspect of right iliac blade. Patient was disease-free for 8 years, interval scans not available. Case summary till now: 50-year male, case of oligometastatic carcinoma prostate, post GnRH antagonist and ADT for 3.5 years, post pelvic radiotherapy and SBRT to right iliac blade.
So, what is the definition of oligometastatic disease?
So, oligometastatic.
You have to tell the audience, no? Like oncology background, you know, but your audience doesn't know.
Okay. Oligometastatic means metastasis which is not more than 5 or more than 3, but not less than 5, and it's not involving more organs. Small sites are present, which is 3 to 5, ranging from 3 to 5 sites. In 2024, patient then developed complaints of right flank pain, for which he underwent following investigations: USG abdomen and PET-CT. USG abdomen showed 8.7 into 8.1 centimeter size mass involving interpolar region and lower pole of right kidney. Now this shows that he had some other malignancy. PET-CT suggested of mid and lower pole empty sheared exophytic soft tissue lesion measuring 94 into 75 into 74 mm with SUV of 8 reaching up to Girota's fascia. No involvement of renal pelvis or renal artery. This is suggestive of right renal cell carcinoma. Prostate is unremarkable and visualized bones are unremarkable with no other evidence of distal mets. Patient had radical nephrectomy on 12th July 2024. Histopathological reported all were these done outside, was suggestive of upper middle pole lesion measuring 11 into 8 into 8 cm, clear cell renal carcinoma grade 2, PT2B NXNX. Case summary till now: 57-year male, case of metachronous malignancies, oligometastatic carcinoma prostate, post GnRH antagonist and ADT, post radical radiotherapy, post SBRT, that is stereotactic body radiotherapy, to right iliac blade, and right renal cell carcinoma, post radical nephrectomy. Patient then developed lower urinary tract symptoms and then consulted elsewhere. Again, he went following investigation that was done outside by other centers, which revealed with suggested that right posterior lateral peripheral zone of prostate showed lesion of around 12 to 12 mm mass with no involvement of seminal vesicle, urinary bladder, and periprostatic fat, rectum, and atrial wall with no lymphadenopathy. Now, this is suggestive of recurrent carcinoma prostate. Right kidney not seen, no evidence of distal mets. PSA 15 nanogram per ml, which is high. Trust-guided prostatic biopsy was done outside that showed adenocarcinoma, Gleason's score 4 plus 4 and grade group 4 with prostatic tissue involvement by a tumor less 50% with lymphovascular invasion not identified but peridural invasion present.
So what is trust guided? Just tell the audience. When you use an acronym, you have to expand it.
Transrectal ultrasound guided prostatic biopsy. This is done by transrectal route.
And when you show a relatively uncommonly used test, you have to show the normal reports in the bracket. No? PSA for you and me is every day,
Yes, sir.
but maybe for your audience it's not every day. So what is the normal PSA
Okay. So
you
for
should
this,
have over there?
yes, sir. As this page is early in age, 58 year, which is not very common for CA prostate. So normal range for this age should be around 0 to 3.5. Here this is 15. Now, patient presented to our OPD, Radiation Oncology OPD at MGH in May 2025. Patient was vegetarian in diet, sleep and appetite was adequate, bowel bladder normal with no addiction. Family history was not significant. General physical examination was grossly normal. Systemic examination was again grossly normal. In local examination, we did digital rectal examination that showed discrete firm nodule in right lobe of prostate. Gland surface is irregular, asymmetrical, mobile, non-tender, normal, and smooth rectal wall. Case summary: locally recurrent carcinoma prostate, grade CT2A N0M0, that is high risk, grade group 4, PSA 15 nanogram per ml. Thank you so much. Now I would like to call Dr. Kavita Bhati to discuss about the treatment plan. Thank you.
Good morning. Myself, Dr. Kavita Bhati, Assistant Professor in Department of Radiation Oncology. So this case was a biopsy-proven case of locally recurrent CA prostate with history of prior radiotherapy. So the patient was considered for local therapy, for which the options are it was a case of re-irradiation, low dose rate brachytherapy, high dose rate brachytherapy, EBR, conventional radiotherapy, and stereotactic body radiotherapy. Other options are surgery, cryotherapy, and high intensity focused ultrasound. So selecting the case for radical radiation therapy versus radical prostatectomy, the meta-analysis showed similar disease control, and the cancer-specific survival and overall survival is better with radical prostatectomy in early and intermediate risk groups, and radiotherapy has better biochemical recurrence-free survival and metastasis-free survival. In high-risk cases, radiotherapy is as effective as radical prostatectomy when combined with the systemic therapy. So the treatment, radiotherapy treatment options: external beam radiotherapy, it has a conventional radiotherapy and stereotactic body radiotherapy. In conventional radiotherapy, the dose delivered is 75 to 80 gray in 37 to 40 fractions over 8 to 9 weeks. And in SBRT, a high dose is given per fraction and the treatment is completed in 4 to 7 fractions in 1 to 2 weeks. And this is the major difference. In brachytherapy, there are radioactive implants that could be temporary or permanent. So why not a conventional radiotherapy in this case? Conventional radiotherapy requires large treatment volumes and greater exposure of bladder, rectum and urethra, increased risk of late genitourinary and gastrointestinal toxicity. The treatment is delivered over multiple weeks, and so patient compliance and lodging is an issue. And in re-irradiation with conventional technique, it is technically possible, but the risk outweighs the benefit. Why SBRT and cyberknife in this case? SBRT, it delivers high precision hypofractionated radiotherapy, and that has a biological advantage in prostate cancer. In CyberKnife, it has a robotic arm with real-time fiducial tracking system. No rigid immobilization is required, that offers patient comfort. There is steep dose fall-off, so the better sparing of the organs at risk. The CyberKnife is uniquely suited for salvage prostate radiotherapy. SBRT and brachytherapy both are suitable in the patient with a locally recurrent CA prostate. In brachytherapy, younger patients with where we want to escalate the dose with a small prostate and minimal lower urinary tract symptoms, it is more suitable. And patients who prefer non-invasive, time-efficient therapy and who has baseline lower urinary tract symptoms, there the SBRT is more suitable as the brachytherapy can aggravate the symptoms. The recent trials, there are several trials that support SBRT in CA prostate, like PACE-A, PACE-B, and PRIME trial. And all these trials, they suggest that the SBRT is effective and convenient option with non-inferior oncologic outcomes. Toxicity and quality of life depends on fractionation, image guidance margins, and the ADT use. So the treatment options considered were salvage surgery, that was not preferred by this patient. Conventional irradiation was not possible due to increased risk of late toxicity. CyberKnife with SBRT is the most suitable option for this patient, as he also wanted minimally invasive and shortest treatment. So the patient was planned for CyberKnife SBRT. While planning, these are the several steps that we have to go through, and the patient is taken for planning to execution. The first step is fiducial placement. For that, we referred the patient to the Department of Interventional Radiology. I would like to invite Dr. Anshul to explain the fiducial placement.
Thank you, Dr. Kavita. Good morning, sir. Good morning, everyone. I am Dr. Anshul Sood, first year DN resident in the Department of Interventional Radiology. I'll be explaining you about the deployment of the fiducial marker. So before understanding the deployment, let's understand what fiducial marker actually means. So the term fiducial is derived from the Latin word fiducia, which means trust or confidence. The term reflects their function as a trusted, reliable reference point that provide a fixed basis for comparison and indexing in imaging and measurement systems. These are the tiny implanted metal seeds, often gold, placed in or near the region of interest to provide an accurate, real-time reference point for the image-guided radiation therapy. The markers help radiation oncologists to accurately target the radiation to the region of interest, thus reducing the damage to the healthy surrounding tissues. These markers are small, in 3 to 5 millimeters in length, are made up of gold, mostly gold or platinum, are cylindrical in shape or can be in coiled configurations, and are delivered via 17 to 21 gauge preloaded needles. The standard protocol for the fiducial placement includes a minimum requirement of 3 to 6 fiducials in number in or around the lesion, and they should not be placed more than 5 to 6 centimeters away from the lesion. A triangular configuration is recommended, which involves the placement of markers in the base, in the mid-gland and apex of the lesion. So two primary approaches exist for the fiducial marker placement in the prostate, that is the transrectal approach and the transperineal approach. Both the approaches have the same percentage of accuracy and complications as proposed by the recent literatures. So for the procedure, the implantation of the fiducial markers is done under the guidance of the image guidance. It is a minimally invasive procedure and is done on the OPD basis under local anesthesia. So I'll be explaining the placement of the fiducial marker using this cinematic video. This is a cartoon image showing the bladder, prostate, and the close proximity of the prostate with the rectum. So after the application of the xylocaine jelly in the anal canal to sensitize the area, a transrectal ultrasound probe is inserted through the rectum, and the close proximity of the prostate with the rectum ensures the easy visibility of the prostate via the ultrasound probe. So after the placement of the ultrasound probe, the whole prostate is scanned and the lesion is being identified. After the identification of the desired lesion, using the coaxial needle or the placement needle, the needle is inserted into the region of interest or around the region of interest, and the fiducial markers are placed. So after the placement of the fiducial marker, it is important to take the X-ray or the CT scan to confirm the location. So coming to our patient was a 58-year-old male with a recurrent history of carcinoma prostate, who on PET CT scan showed a FDG avid nodule in the right posterior lateral aspect of the prostate gland, as can be depicted by the arrows here. And on transrectal ultrasound approach, the lesion was confirmed and is delineated by the markers here. So after delineation of the lesion, using the fiducial marker needle, the fiducials are placed around the lesion. And this is a transrectal ultrasound image which is showing the placement after the placement of the fiducial marker, which is showing the fiducial, and this is a trans-abdominal ultrasound image which is showing the fiducial markers.
How many fiducials?
Sir, in this patient, 4 fiducials have been placed. Yes. So after the placement of the fiducial, it is important to take the X-ray or the CT scan. So the X-ray of the pelvis shows the placement of the fiducial, and the CT scan demonstrates the same. So after the placement of the after the fiducial placement, it is important to understand the marker position. So within 1 to 7 days of the placement, a pelvic X-ray is required to confirm the position of the marker. So for the treatment planning, a CT simulation is required after 1 to 2 weeks, and minimum 1 week interval is required between the placement and the simulation to allow the marker stabilization. Now I would like to invite Dr. Diksha to take forward the case.
Thank you, Dr. Anshul. Thank you, Dr. Anshul. Now I would like to proceed further with the treatment steps. So our step is first pre-simulation preparation. But before that, I would like to give a brief discussion about simulation. What simulation means? Simulation means simulating treatment which involves immobilization using a vac log and baseline CT scan on which the targets are drawn. Vac log will be discussed in our further slides. Patient was scheduled for radiotherapy simulation 7 days after the fiducial placement. These 7 days are important so that the fiducial markers can get stabilized and prostate swelling can subside. Thereafter, we followed 2 protocols, that is rectal and bladder. In this patient, we asked the patient to stay empty stomach before simulation and given 2 tablets of Dalcolex HS night before the simulation, followed by CT scan to confirm empty rectum, which is done the other morning. Rectum was still loaded, so we prescribed PC enema to the patient and repeated the CT scan which showed empty rectum. Similarly, we followed the bladder protocol as the treatment time exceeds 30 minutes in cyberknife-based SBRT. So we have to ask the patient to avoid urine completely prior to simulation and treatment to achieve the least displacement of internal organs. Second step, immobilization. This is the most crucial step for our treatment. Immobilization is done in supine position and hence over the chest using vacuum cushion. So this is the vacuum cushion. Now this is airtight nylon sheet which is filled with the free-flowing polystyrene beads. So when the air is sucked out via vacuum pump, the beads get compact and locked into the patient contour. Hence this is comfortable and reproducible patient immobilization setup because patient has to lie for 30 minutes. The third step, CT simulation. Patient is planned for CT simulation. A plain CT pelvis is done with axial cut of 1 mm through the pelvis and prostate from the top of the iliac crest superiorly to the perineum inferiorly. Here the show is the CT simulator, and this is the vacuum cushion on which the patient is lying supine. Third step is planning MRI. That is done on the same day of CT simulation with bladder and rectum protocol as we follow, which improves the gross tumor volume, that is GTV delineation. Other better organ at risk delineation. Organ at risk are the organs that are most at the risk or can get the extra dosage which is not required. That organs are bladder, rectum and urethra for this case. It reduces the uncertainty essential for re-irradiation, differentiates local recurrence from scar tissue or post-radiation changes. Followed by CT-MR fusion. Now this is also important as now MRI is co-registered with our planning CT to ensure accurate anatomical mapping of prostate, bladder, rectum and urethra. Followed by contouring. As per the ESTRO guideline, that is European Society for Radiation Oncology, and ACROP guideline, that is Advisory Committee on Radiation Oncology Practice, we draw few target volumes that include gross tumor volume, GTV. Now here it is depicted as red line as indicated on the CT-MR fusion images. Thereafter we meet PTV, that is planning target volume. This is the blue line showing 5 mm expansion of GTV cropped to 3 mm towards the organ at risk. These are the organ at risk that we contour, which are very essential to protect these organs from extra dose. These include bladder, rectum, bilateral femoral head, penile bulb and urethra. But for these patients, intestine is not required as this is a set template, but we don't require intestine in this case. Then we described a prescription dose that was 35 grain 5 fraction, which means 7 grain per fraction. After contouring, the case was further taken up by the Department of Medical Physicists. Now, I would like to call upon Mr. Praveen Kumar to take up further.
Thank you, Dr. Diksha, for introducing me. And good morning to all. Myself, Praveen Kumar. I am a senior medical physicist working on radiation oncology department. I will be discussing the planning part of our patient. Me and my team is privileged to have opportunity to work on one of the ventures in radiotherapy machines, which is a CyberKnife, across 12 centers in the country, of which the latest S7 model available only in 3 centers across the country and only 1 in the Rajasthan. So here comes the CyberKnife. So we have a robotic linear accelerator in the CyberKnife system, and real-time intra-fraction prostate tracking with fiducial is one of the greatest advantage of this system, which is not available in any of the conventional linear accelerators. And we have a sub-millimeter accuracy and with targeting error of less than 1 mm. So the purpose of doing pre-planning procedure is that to verification of the placement of fiducial with respect to target and aligned to the CyberKnife system. So here comes the treatment planning. In planning, we have a ray trace algorithm used to reduce the overall treatment time of the patient. We have a many number of non-coplanar and non-isocentric beams that can be applicable only in the CyberKnife system, and we have 1400 beam angles for the treatment with 6 degrees of freedom of robotic arm. So, in treatment, after the treatment is done, the dose constraints has been achieved, and the general dose constraints that is followed, and we have achieved bladder, rectum, penile bulb, which are more which is considered as a priority OARs, which are well versed within the guidelines limit. So after once the plan is done, the plan is evaluated by the senior radiation oncologist, and then it has been ready for the quality assurance test. Quality assurance test is nothing but it is a plan which is made on the phantom to deliver it with the chamber, and once the QA has been passed with the tolerance limit of 5%, plan is valid for a treatment delivery. So during the treatment delivery, prostate can move for the intra-fraction motion which can vary from 1 to 10 mm over seconds to minutes, which we have placed 4 fiducials in this patient. So the minimum requirement of the 3 fiducials are taken into account for the possible types of the movement. So like translational and rotational movements. So robot can correct the translational corrections and standard couch and the robotic couch, which has to be corrected before start of the treatment. Here comes the cyberknife is rotating all around the patient to treat the cancer. So we have 1,400 beam angles, which is not available in any of the conventional linear etc. as I have mentioned. So there are 2 X-ray systems available here, so that can verify the patient positioning as well as the fiducial tracking. The fiducial tracking is done by the fiducial tracking algorithm, and once the algorithm has been tracked, then the patient is ready for the treatment. So it has a high throughput as well. So during the difference between the conventional and robotic treatment is, as we need in conventional large margin size and increased treatment time, the cost of delivery also will be higher, but compared to the cyberknife, we have a less margin for the treatment and increased patient satisfaction and with the lower cost. So here comes. Thank you. I'll invite Dr. Kavita to lead further.
So why should the prostate move? Normally structures continuated with respiration movement is related only to diaphragmatic and related structures. Deep down in the pelvis, why is the prostate moving? That is one question for you. And the other thing is that how do you do, what is your goal when you say 35 gray, why not 45 or 25 gray as the total dose of radiation? Is that the dose meant to completely evaporate the prostate, or I mean, what is the factor that makes you decide the dose?
Actually, it's a clinical.
So doses are actually decided by the clinical trials, and it is different phase 1, phase 2 trials, and it has been decided upon that it is 35 gray and 5 fractionation is for the ablation of the lesion. That is complete eradication of the disease. Prostate disease, because we will not remove the gland cell. And this first part is yours. Movement is due to the rectal and bladder movement is there. So due to that movement is there, and internal movement of the prostate itself is there. So we have to track that movement, because it's some millimeter accuracy we are delivering. So even if we miss the 1 mm, we'll miss the lesion. So that's why we have placed the marker all around the lesion, and we'll track that margin and will not miss the prostatic lesion during the treatment, because very high doses are given.
Even the bladder and the rectum are not mobile structures.
But sir, rectum can fill and bladder can fill during the treatment. So we have 30 minutes. That's why we have kept the rectal protocol, strict rectal protocol and strict bladder protocol. Because 1 mm movement is there, will miss the game of the patient. Sir, nice. Because it will again then artifact will come.
So our patient had a localized recurrence in the prostate bed with no distant disease that was suitable for targeted local therapy. Recurrent prostate cancer after primary treatment is a challenging scenario. Achieving bladder and rectum dose constraints are challenging due to prior high dose. Cyberknife enables sub-millimeter accuracy, making this hypofractionated approach safe. This was our case was the first prostate cyberknife at our center with fiducial tracking. Why this case is special? This case showcased our team's ability to manage a technically demanding procedure, fiducial placement, image fusion, motion management. It opened the pathway for future prostate SBRT patients in our department. It demonstrates how advanced technology can translate into better outcomes and quality of life. Recurrent prostate cancer requires precise and patient-tailored treatment. I would now invite Dr. Diksha to conclude the case.
I would like to discuss response assessment. Patient was followed up clinically on 1, 2, and 3 months. No radiation-induced toxicity was there on follow-up. PSA was suggestive of 0.78 nanogram per ml. MRI was suggestive of no area of abnormal signal intensity in prostate. Patient remained asymptomatic with good quality of life. Patient was further referred to Department of Medical Oncology for further management, as patient was comfortable with his own hometown, so he preferred to take further management from his own hometown. Now, I would like to thank, we extend our sincere gratitude to Mahatma Gandhi Hospital and management, respected faculties and CCR Review Committee, Department of Interventional Radiology, to patients and their families. Thank you.